October 12th, 3 p.m. Eastern, same time. All the webinars that we've done, including the webinar for today, are recorded and they're available at the HVHC Safety.org website. So please go there. We usually take about a week to get the newest webinar posted, so today's webinar should be there by next week sometime. And we'll send an email out to everybody and send it through the program management office as well to let folks know when that's available for viewing. Two other reminders is on August 15th is the deadline for the sepsis data submission, and if there are any questions about that, it's Jay Knowlton at the program office is the primary contact for that. And then, as I said, the third quarter pulse check, they're still accepting responses for, but just to kind of keep everything on your radar, the next pulse check will be coming out in late September. So keep an eye out for that as well. And final reminder that I had was just for the dissemination and implementation site that is on the HVHC website, where all the resources that are available and being shared from the organizations, member organizations, are available. And again, these are all resources that are sent in from the member organizations and then vetted through a peer review panel of HVHC members and posted to be made available to everybody. So if there's any questions on that, contact the program office, but it's an excellent resource, so we're not all reinventing the wheel. So with that, I'll go ahead and turn the time over to Izzy. And right before I do that, if I could just remind folks, since we've got quite a few people on the phone, if you wouldn't mind muting your phone during the presentation, there'll be plenty of time at the end for Q&A. And if you do have a burning question, you can raise your hand in the presentation, or I'll leave it up to Izzy if she's okay with interruptions mid-course, but there'll be plenty of time for Q&A. So I will turn it over to Izzy.
Thank you very much, Jason, and really thank you. I'm really honored that you asked us to present. These are things that we do every day as part of our care of the patient, and so it really is an honor when you're asked to present the work that you're doing to your colleagues. Nick Bitterman did speak to Lucy and to Jason earlier this year, and he described the year of the fluid to her, and so we were asked to present at the technical expert panel, and then again we were asked and honored to present to you today. So this is the year, or actually now it's the years of the fluid, because as we know, change is slow and meaningful change is even slower. So in a large system with many hospitals, like ours, and most of you out there have large systems, you all know that sustaining change is very, very difficult. So what I'm going to do today is tell you our story. And the reason that I'm going to tell you the story and the whole genesis of our task force and collaborative is that the structure that we have built that we found invaluable in assisting our teams in making that small incremental change that we hope and has shown to lead to more sustained progress. So, next slide. So the agenda today is I'm going to describe for you how our Sepsis collaborative / task force, sometimes we use the terms interchangeably, and its structure is integral to understanding what we're doing with regards to fluids. And then what I'm going to do is I'm going to try and share with you some of what we believe are promising results so far. Next slide. So in 2008, our president and CEO decided that sepsis was going to be a system-wide initiative. Way back in 2008, we only had 11 hospitals. I believe now we have 22, if I'm not mistaken. But I may be mistaken. The number changes weekly over here. So what happened is we called together senior clinical leaders, senior nurses and physicians, pharmacists, from across the system, and convened an interprofessional group. At that time, the group was from the ED and the ICU, and they formed what we call the Sepsis Task Force. And Mr. Dowling charged the group with reducing sepsis mortality by 50% in the next 5 years. And at that point in time, I believe we were at a 36% mortality rate, which was not good in those days. So the initial focus of the task force was decided that we decided it was going to be the ED. Why the ED and not the ICU, which was one of the original ideas, is that the ED catches the patients upstream. And so we're able to identify those patients earlier and hopefully improve the outcomes. Since 80% of the patients in our health system that present with sepsis come in through the emergency department. Once the patient is admitted to our ICUs, the opportunity for early recognition has probably passed. Next slide, please. So the task force evolved into something larger that we call now the Sepsis Collaborative. We worked with IHI at the beginning in order to set up our structure and to start to get an idea on how to build this larger structure. So we put corporate structures in place that foster individual team success, and that corporate structure also gives us a lot of clout at the hospital level. The Department of Clinical Transformation, which is the department that I work for, is responsible for administering and for supporting the Sepsis Collaborative. And we do that by providing what we call executive sponsors. So those are senior, really senior administrators, senior vice presidents. So Marty Dorfler, who's the senior vice president for transformation, is one of our senior sponsors, executive sponsors, as is Dr. John D'Angelo, who is the chair of the ED service line. And so those are the people that we are looking at for our executive support. Then we have a dedicated nurse administrator, and that's me. I work with 2 other chairs, and they happen to be physicians, 2 physician chairs. One of them is an emergency department specialist, and the other one is a hospitalist. And we work together to help to guide the collaborative. We cannot work in a vacuum, and we also have a dedicated member of our improvement science team that we call the improvement science mentor, and that person is available to everybody and anybody in the Sepsis Collaborative who needs assistance in running their PDSAs or their quality improvement cycles. I also have the pleasure this year of having a project manager assigned to me who helps to keep me on track to make sure that everything that we do is in a timely fashion. We have a data support team, the Krasnov Quality Institute, and I'll describe what they do for us a little bit later, but they are our data support people for the entire health system. And we've provided education on a system level so that people don't have to reinvent the wheel, so they're getting the same information across our learning management system. Next slide, please. So, to continue with our corporate structure, now we're down to the hospital level. Each hospital is responsible to have the sepsis team who is part of the collaborative. The composition of that sepsis team includes a sepsis site sponsor. The sepsis site sponsor is the person at the site. It's usually a CMO, a CEO, or somebody with the power in order to drive the initiative. They provide the team with the resources that they need in order to succeed, which is time to do their work, assigning people the responsibility of belonging to the task force. They also have what we call a sepsis team lead. The sepsis team lead is the person who's the boots on the ground, the person, our contact person, the person that is responsible for getting the team together, holding the team site meetings, and running all the PDSA and the quality improvement work. We have sepsis champions, and those are people in individual units or departments who have a love for sepsis, and they're the ones who work with the team lead along with members of the sepsis team in order to collect the data and to make the change. Next slide, please. So, in the collaborative structure, every hospital in Northwell currently has an inpatient team and an ED team. The ED team has been in place since way back in 2008, where our inpatient teams only came about in about 2012 or 2013. We brought in the inpatient team. We started obviously with the ED team because we know that the ED is where all our patients come in. So the hospital teams work at their sites, and what they do is they adapt best practices using their local processes. Anybody who's part of a larger system knows that the teams, that each hospital doesn't have the same resources, the same staffing patterns, or even the same laboratory patterns. And so this is why they take things back to their site and adapt it, whether or not they have an EMR or whether they're still on paper. The site teams meet locally. They all come together. They meet locally once or twice a month, depending on what the teams require. And all the site teams come together in a larger group bi-monthly with us as part of the Sepsis Task Force and part of the Sepsis Collaborative Call. The Sepsis Task Force, anybody who's involved in sepsis is welcome to the task force call. And that's an hour and a half every month where we discuss any and all issues and concerns related to sepsis, related to data collection, related to our DOH, our New York State DOH, which is a big issue here in New York State, our Department of Health. Anything to do with the new CMS measures. And then once a month we have what we call a Sepsis Collaborative Call. And the Sepsis Collaborative Call is where all the teams get together. They present their individual PDSAs and the work that they're doing, and they share it with each other so that we can share best practices, lessons learned, and actually we can share our failures also, because we also learn from our failures. We also have quarterly sepsis learning sessions, and we hold those in a country club, usually, or in a large venue, and we actually feed people. You feed them, they will come. And what we do at these learning sessions is that we have speakers recommended by, we get speakers based on the topics that are suggested by our team members or things that are actually happening in the sepsis community at the time. And then the last thing that we do is, at least annually, myself and the two clinical chairs go to each individual site and we visit the teams during their team meetings so that we can get a sense of any challenges that might have. And while we're there, it's not a gotcha session. It's more of, wow, you're doing wonderful work, and the whole team is there, and we get to meet all the people at all our sites. Okay, next slide, please. So just to go into a bit of detail about what we provide on a corporate level is we are improvement science team. So we have a dedicated improvement science team, and it's 6 to 7 members that work out of our department. Their job is to educate and support in the structured approach, a structured approach for process improvement using that PDSA methodology that we spoke about earlier. The teams are required to upload their PDSAs to a share site that we have at least monthly, and then they're given actual written feedback from their mentor so that they can then update their PDSA work. Then they have that corrected PDSA in order to present to the team during our collaborative call. Also at our learning session, we have something we call the gallery walk. And the gallery walk is where the teams actually make posters of their PDSAs, and they highlight their work and share best practices. And then we get feedback from our sepsis chairs highlighting different issues that the sites have had. And so we ask the teams to please feel shamelessly take the ideas back to their sites and work on their own processes to put the successful processes forward. The Krasnov Quality Institute that I alluded to earlier is a department that was developed and maintained. It was developed and maintains for us a uniform, standardized sepsis database. So So that ensures for us reliability and accuracy in our sepsis data collection. So not every hospital is doing whatever they want, collecting data any way they want, and reporting things any way they want. So it captures all our demographics and all our clinical data elements, so it's a huge resource for us if we want to do research also. The KQMI, or the Krasnoff Institute, also assists our site abstractors when they have reports to generate either to the state or to the federal government. And it generates all our outcome data. All our sepsis outcome data emanates from KQMI, from that one standardized database, so that we can be assured that the information that we're putting out there is actually accurate. And last but certainly not least is sepsis educational support. We were fortunate enough to get a 3-year HRSA grant for sepsis on the nursing level. So we developed the Training Sepsis Education Program, or TSEP as we like to call it here. And we copyrighted it. We had videos made for it, professional videos, professional voiceover. And we made that available with sepsis simulation to our nurses. And then we adapted it to physicians, and it's in many different flavors. It's in pediatrics, critical care, emergency department, and med-surg. And we adapted those same modules to a physician level. And they have a pre-post test, so we are able to state that with statistical significance, the program did impact learning. We also have a different level of physician module because our attending physicians felt that the TSEP program may be a little bit too granular for people who are experienced, and so we made a module for attending physicians, which is just on our learning management system as of this month. So that's the collaborative structure. Next. So now this is what you all really came here to hear. And so I'm going to tell you how and why we decided that it was going to be the year of the fluid. So in 2014, we looked at our data, and we saw that we were really sustaining improvements in those first 3 elements of the bundle that you're all painfully aware of. And so that's drawing the lactate, drawing your blood cultures, and, I can't remember the third. So drawing lactate, drawing blood cultures, getting your antibiotics up in a timely fashion. So we were doing rather well on that, and we were sustaining it. And where we were really falling short and had really hideous numbers was on our fluid administration. So the task force decided to turn its attention to that. So the faculty, and the sepsis faculty meets, it's a small group of clinicians that meet, and we set the standard with our corporate sponsors of the task force. We met, and we decided that we were going to devise our own standard. And we decided that if we started fluids within 30 minutes of the sepsis identification, that we would be able to meet our 30 mL per kilogram fluid compliance within the first 3 hours of the bundle. So we were charged with putting that standard across to the whole system. So that's when we actually decided that it was going to be the year of the fluid. So that was our standard that we set. Next slide, please. So in 2015, we focused all our attentions on fluid administration. So we started out with our improvement science team. We actually rebooted all the site teams by working with them and creating and analyzing their swim lane diagrams so that they could identify any bottlenecks that were in the process, so that each team could focus on a specific problem area of fluid administration on their PDSA. Then we shared all the best practices, failures, and lessons learned during our collaborative calls, so that every month people could walk away with an idea or a strategy that they could probably try in their own facility that had helped another department, another hospital. All our learning sessions were our educational focus was on fluids. So we had our physician leaders and leaders in sepsis present on fluids and the importance of fluids and the impact of fluids on our patients with sepsis. And our site visits also were focused on fluid administration best practices. Next slide, please. So again, just back to corporate support. When we decided that the 30-minute standard was going to be our standard in the system, the corporate at a corporate level, they decided that was going to be a quality vector for all Northwell Hospital sites. So what does that mean? That means that is one of the quality measures that all hospitals must meet for the system. It became part of each hospital's dashboard. Every CEO and CMO and every single and system leadership have had fluid administration, this standard of 30 minutes of starting fluids from identification of severe sepsis, is part of their executive scorecard, and it's a component of their compensation calculation. It was for 2014. It was for 2015, and I believe it still is for 2016 for all executives. So as we know, if you want compliance, you have to hit them where it hurts, and that's their pocket. So that's a real big incentive to our hospital leadership to be compliant with our 30-minute standard. So the data on the 30-minute standard is monitored by KQMI, and monthly reports and graphs are generated and displayed on our intranet. And so that makes it very transparent to all of us. So that's a real big incentive. It's that competition factor, and we all know that competition is healthy. And so every team can look at their brother and sister hospitals to see how they're doing, and it does build a very nice competitive edge. So, moving on. During our hospital collaborative calls, our site visits, and during our gallery walks at our learning sessions, we were able to compile a list of best practices that we shared with all our teams. So we were able to have, through this structure, the teams design and test their different strategies using the improvement science methodologies, and how this collaborative model allows us to disseminate them and give the teams the forum to be able to discuss any questions that they might have. So our rapid response teams with clearly defined roles, including a scribe with test tools that include the bundle elements, was one of the best practices that we shared. So these are the actual best practices that we shared with people. And so the scribe, like we used in ACLS or PALS, became a tool that one of the sites used, and the scribe saying, have we thought of fluids? How much fluid are you giving? How much is the patient weighed? Was really very significant in that. Also, we're trying to standardize the sepsis screen on our EMR. So we have actually a subcommittee of our task force working on the sepsis screen, so that once we develop a screen, every hospital in the health system will have to use that screen, and we are making the screen transferable to the EMR. So when the people who do the data development get our document, they'll be able to transcribe it easily into the EMR. Another site had weekly reviews of RRTs and code sepsis cases. So that increased awareness and identified discrepancies in our fluid administration, and was able to get back to the teams in a timely manner. We also one of the sites has encouraged their physicians to use the acute sepsis order set to facilitate the amount of fluid ordered, because a lot of our physicians aren't really happy with the sepsis order set, and so they bypass it, and in writing their orders, sometimes they don't put the right amount of fluid into the order. Okay, next slide, please. I presented at the spring conference the sepsis toolkit, and the sepsis toolkit contained 2 liters of crystalloid right in the box. So when you open the box, the fluid was there looking at you, and so is the IV tubing. One of our other sites took that and has a travel bag, a sepsis travel bag, with pretty much the same contents. They just adapted it to whatever they need at their own site. One of the sites has monthly education and re-education of the house staff on sepsis and fluid administration. Another site improved their documentation on the EMR by educating the staff so that they were standardizing the fluid documentation in a particular part of the chart, which then assisted our abstractors in finding the accurate data, because not all the sites would document their fluid administration in the same place. Then another site has just-in-time performance feedback. So the quality team takes the RRTs or the code-sepsis reports and reviews them and then sends a feedback letter, whether that's an attaboy, you did a great job, or this is what we found, this is what we need you to do in the future letter. And they found that incredibly important so that we could speak to the clinicians, nurses and physicians, in a timely manner so that it wouldn't be like 3 months down the road where they would forget the patient and or the incident. Next slide, please. So where are we now? Next slide, please. All righty, so I don't know if you can see the little dots, but I'm going to try to walk you through them the best way I can. In the upper left-hand corner is the graph of blood cultures prior to antibiotics. So we are hovering around the average of 75%, and we have been since 2014, so we're kind of holding steady there. In the upper right-hand corner is the lactate order resulted within 90 minutes. So I don't know, it may be a little hard for you to see, but the last 6 data points are exceeding our average of 82, and so we're hoping that since this is health system, this is 22 hospitals data, that it is hopefully a significant rise, sustained rise in our lactate orders. The lower left is fluid bolus within 30 minutes. And if you look at it since March of 2015, we're above the average of 52%. And we're hopefully going to be able to move that average a little bit higher. On the lower right, we have antibiotic administration within 180 minutes, and you can see that the last 3 data points are exceeding our overall average of 81%. So that's looking a little bit better also. Next slide, please. So our next slide, those are our 4 sepsis fluid-specific metrics. And as you can see, as I told you before, these are all generated from Krasnov, so it's not like anybody is able to have their own way of calculating their fluids. In the upper left is time to fluid bolus. I know it looks to the clinicians like the graph has a little bit of VTAC, but if you look at it, the last 6 data points are trending upward, and we are getting closer to the 30-minute target. Where I think we're at like 28.7, so we are almost to the point where we're giving patients at least 30 mL per kilo of fluid. In the upper right, percent compliance of fluid within 30 minutes, the last 7 data points are above the average of 52%, so we're really happy about that. That's looking very promising. In the lower left, the average volume per kilo, the last 3 data points are above our average of 29 mL per 29 mL per kilo volume average. We are so close to that 30 mL per kilo mark that we can taste it. And in the lower right, the percent compliance for administering 30 mL per kilo, the last 3 data points are above the current overall average. And next slide, please. And so the last slide is our mortality rate. From the time our president and CEO charged us with decreasing our mortality rate. So you can see that we've had a sustained, consistent decrease in mortality since 2008. And we did meet our goal to reduce mortality in those first 5 years. As a matter of fact, I think we hit the goal within 4 years. We're happy to say that we currently at a 12 to 13% mortality rate, which achieved about a 60% reduction from where we started in 2008. We are not thrilled with that because our overall goal is to reduce and sustain our mortality in the single digits. And again, you all know that the closer you get to 10% and under, the harder it is to move that improvement in the process. It takes longer and longer. But we are moving in that direction. Last slide, please. I know you all like it when I say last slide. Okay. So what are our future plans? So we're going to continue working on the bundle elements with the focus on fluids. So we want to make sure that those 3 bundle elements continue sustained, if not continued improvement as we have had in the last number of years. And we are following our fluids very, very closely. And this just happened last week, folks, so you're getting news. So what we did last week at our task force is because we have been getting our CMS Step 1 measures, it was identified by entire Northwell that our repeat lactate measure is the one that we're falling short on a lot. So what we're doing now is the whole task force is going to shift its focus to repeating lactate. So why did I go through all the pain and put you through hearing all about our task force and our collaborative? Because we do have the structure in place now to be able to turn on a dime. And so now we've identified the repeat lactate as an issue. We're going to be focusing for the next couple of months our collaborative calls, our task force, and our learning session in September to getting the teams to redo their swim lane diagrams, to identify their bottlenecks, and to start working on their PDSAs to improve their repeat lactate. And what we're really hoping is that when we improve those repeat lactates, we'll have the extra added benefit of moving the fluid measure. So we're not really turning away from fluid. We're just taking a slight detour to focus on something else that will ultimately help us with our fluid measures. With that, I think that's it, and I want to thank you all for your kind attention, and I invite any questions and hope that I can answer them for you.
Thank you, Izzy. That was great. So if you do have any...
Thank you.
Thanks. If you do have any questions, just remember to unmute your phone, and we'll just open it up. Well, maybe as people are formulating questions, I have a couple. So, going back to your data slide. So first of all, I just, a general comment. I wanted to say how much I appreciated that in all of these slides, you had the little arrow at the top of the chart that said which direction is showing improvement and which is not. I think that's really important when you're showing these to the teams, to clinical teams, to easily see how you're doing. But in relation to these, it seems pretty common, when you focus on one certain component or one element bundle, like with the fluids, it is likely that other things tend to fall off the radar and decrease, and that, based on most of this data you showed, didn't really happen. And I know you had said for what's happening next is to focus on all bundle elements, but could you maybe talk a little bit more about any concerted efforts that went along with these years of the fluids to ensure that other bundle elements didn't fall off?
Oh, well, yes. So although we're focusing on fluids, so sometimes we have new hospitals that we acquire that join our task force. When we go to visit them, we do a site visit to introduce the collaborative to them, and we meet with their senior leadership and with their sepsis teams, and we introduce all the corporate structure and the site responsibilities that I explained to you today. In addition, our improvement science team will either visit the site or have a session at a central location where the site will actually work on their very own data. So if they're falling short on antibiotics in a timely fashion, that particular hospital needs to work on that element first before moving on to the fluids. So we do customize, and although the focus for the health system is fluids, if another site is falling on their measures or needs help on a particular measure that we already are sustaining on, we will work with them individually to work on that measure. So although we say it's the year of the fluid, and most of our hospitals are working on fluids, if anybody needs to work on antibiotics or blood cultures, then or during the initial lactate, we would certainly work with them on that measure in order to get them comfortable at their own site before inundating them with maybe more difficult responsibilities.
Okay, great, thanks. Any questions from the audience?
Hi, this is Karen Chandler from Dartmouth Hitchcock, and I had a couple quick questions. I came in a little late, so you might have already addressed this, so my apologies if you did. But do you have a nursing per protocol order set that the nurse can start if the patient meets criteria, can start acting on the bundle elements?
By and large, no, not a system nursing bundle. I know I heard at one of the reports how one of the hospitals, and it might be you have the power hour where the nurses
that's
actually...
Long Island. We copied that from Long Island Jewish, but we did use it. But
Well, it was Virginia Mason, I believe.
Maybe it was Virginia Mason. Sorry.
Yeah.
And so, no, we have nothing like that, although we do have the sepsis order set. And so if we can identify the patient early enough and get the physician to activate the order set, or we'll just call an RRT or a code sepsis or a sepsis alert, whatever the specific hospital has. But unfortunately, no, we don't have that power hour. That power hour is really something that I found incredibly interesting and helpful, and they had really a great promise with that. But we don't have anything like that right now because it's out of the scope of nursing practice.
Well, we kept we have the draw the lactate, draw the blood cultures if the patient meets criteria, but you still call the provider. But the area that we're getting the most pushback right now is we have a 500 cc fluid bolus that we can administer, and it's meant to be the provider's on the way to check the patient, and you've got somebody who doesn't look good, you have something you can initiate, and we have a life safety or rapid response team that can respond as well. But we're getting pushback there, and I was just wondering if anybody on the call has experience with that, and did they pull it out? Did they keep it in? It would be helpful to know.
I know that we don't give fluids without a physician order. So if we call a rapid or we call a physician, we would get them to put in an order or take a verbal order in order to start even the 500 cc fluid bolus administration while the physician or the mid-level provider was making their way down to the RRT. So we would require an order for that still. That's my understanding.
And Karen, this is Erin Karttunen from Virginia Mason. We do authorize our nursing staff to be able to start and initiate a 500 cc bolus. Still, a page to the attending provider is also initiated at the same time so that they can make a clinical decision on whether or not to administer the full fluid amount.
Okay, great. That's helpful. And did you receive pushback when you were rolling that out?
Initially, but we responded with physician-to-physician conversations just to understand, just to address, what the concerns were and understand from a high-level perspective why we were doing this.
Okay, great. Thank you. That's very helpful.
Thank you.
And just as reference for those on the call, if you weren't able to join us for the last webinar, the folks from Virginia Mason did present the work they did on this power hour that they've been talking about. And again, you can view that webinar on the HVHC Safety.org site if you're interested. Any other questions?
I thought that Virginia Mason presentation was really very thought-provoking and had a lot of really good ideas that sites or systems should take a look at to see if there's anything that they can initiate at their own sites. It was really quite innovative.
Yeah, it was, definitely. And, I think we've got a good resource here just more generally. There's a lot of really interesting, like you said, innovative work going on among the member systems. And, I think one of our barriers is just making sure others are aware of it because as Virginia Mason has presented that work specifically on the Power Hour, it has prompted a lot of questions and a lot of sites to kind of reevaluate like these nurse-driven protocols and such. So I think it is a really important resource we have here. And, any questions like these that come up, the program office is there to help coordinate and connect you to the right people. So keep that in mind. Any questions before we move on to a review of the pulse check?
Yeah, this is Fritz Krohn at Utah Valley. Thank you for the presentation today. I saw a presentation by Northwell at IHI earlier last year, and it was also excellent. But this is a follow-up to Jason's question. When, with the focus, did other elements of the bundle decline? Do you have any data to show how it all rolls up to step 1?
So we do have our step 1 data, and we are sustaining in our first 3 bundle elements, and where we are falling short is obviously the our weakest, our fluid administration, and our repeat lactate. That's where we're, as you know, once they get a certain level, they stop, and we get no more data from them, but we are falling short. We are getting through the first 3 bundle elements, and we are falling short on the fluids and the repeat lactate.
Okay,
now.
Great, thank you. So ballpark, about where are you on the bundle when you roll it all up? 50%, 70%?
It's not good. It's not fabulous, but we are, I think, within, not that it's, you know what, I really can't give you an exact number. I'd be lying if I told you I had the exact number with me right now, but I want to say 38% rings true, but I'm not positive. I'm just,
okay,
my memory.
That's helpful. Thank you. The bundle's all or nothing, and it is really hard to do process improvement in the early stages from that. So your approach is really excellent. Thank you for sharing.
Yeah. So let me, if I can find a number before we get off the call, a definite number, I will share that with you. Hold on, but Jason or any other questions, go ahead, and I'll try and find that number for you.
Great. So any other questions? All right. Well, let's move on to Paul with the program office to go over a quick review of the pulse check results. Paul?
Sure. Thanks, Jason. So we just wanted to talk a little bit, take a few minutes to talk about the pulse checks and what we're doing with the pulse checks, and specifically with barriers and facilitators. So for those of you on the phone that have done the pulse checks, you'll recognize questions 4 through 10 have to do with barriers and facilitators within your hospital system around different things that are occurring. And then we want to tell you a little bit about how we're analyzing that and any support we have out there as we collect this data, and we report it back during the check-in calls. So really the important thing is, how do we get this information back to you? How can you see this information on your own? So the answer to that is Vantage is the tool that if you do not have a password and user ID for that, please send a note into the help desk at the PMO, and we'll get your user ID and password to get out there so you can look at the pulse check information and specifically for your hospital system and see where you're at. And a little background is we've had 3 pulse checks already. So we've had a baseline pulse check 1, 2, and as Jason was talking about earlier, we've just had our 3rd pulse check that was due by June 23rd. And as another follow-up, if you still haven't done that pulse check, please send it in because you'll see why it's important to look at that data as we go forward. So could you go to the next slide, Jason? So what I did is I just randomly picked one hospital system and threw the information out there on the 7 questions that have to do with barriers and facilitators, just to tell you how we can look at some of the data that comes out there. Now, for those of you that don't know how the questions are laid out, they're laid out from a +5, which is a very strong facilitator, down to a -5, which is a very strong barrier, and anywhere in between. So the first question has to do with how ancillary services, so the pharmacy, the lab, how it affects you to do your 3-hour bundle. The second question with the barriers and facilitators has to do with the EHR. Is that a barrier or a facilitator to implementing the 3-hour bundle? Training is the third question. Leadership support is the third. Clarity of workflow is the fourth, which is not, the 8th question. And your ability to identify sepsis would be the 9th question. And then how other initiatives affect or get in the way of the sepsis initiative. So do you have other things going on that are taking over the workflow or your people's bandwidth to work on sepsis? So if we look at the first one, I pulled this data out for ancillary services. So the first number, 2.7 there, was the first pulse check. So the second number, 2.0, the second pulse check, and 1.5 would be the third pulse check. So all these numbers here are all positive, so they're considered really facilitators, but some are stronger facilitators than others. And you'll see in this hospital system, when we would have our monthly call, we would say, with ancillary services, you were really strong in the first pulse check, and it seems like you're trending down now. And then we would dig into why they were trending down and maybe give some resources out there to help them for the trend going in the wrong direction. Same thing with the EHR. So, but they're going in a trending up positive fashion. So we might ask the questions around, what are you doing to make that to make the EHR a positive influence on the 3-hour bundle? And you could look at each one of those 7 barriers and facilitators and dig in to see why are they trending up, why are they trending down. In this case, for this hospital system, they're all considered facilitators, but if we go and move the bar up a little bit, we can see that some are stronger facilitators than others. So that's part of the monthly check-in calls that we have. Going down to the next chart, Jason, next slide. So this is kind of hard to see, but I blinded out the member systems on the left-hand side. Where in the journey is the next column, so it's either you're not applicable, so you're not doing the sepsis work with the HVHC. You're in process, meaning basically how you are defining yourself. So in process would be, hey, we're still working on it, we're still trying to improve, we're doing active things. And sustaining would be, hey, we're where we need to be, we're not putting any effort into improving, we just want to keep ourselves where we are. And as we go across the columns, the second column would be pulse check, identify barriers. So we go out there, and if we look at I think it's the 5th row down in process, it says 12, 27, and 20, or 21. Those are the number of pulse checks responses that were given. And the pulse check identified barriers there, the level of training. So that's saying that's trending up a little bit. Clarity of workflow is mixed, up and down. And ancillary services, they're trending down. So we're looking at those as being barriers. By the same token, we go next over and say, where are your strengths? So we'll tell the hospital system, your degree of leadership support is trending up. That's really a positive strength for you. Priority of sepsis care is, and among other policies, is up. And electronic health record is also flat, so it's doing good as far as strengths. So So as far as the barriers go, we would look at what resources are available out there on our resource portal to help you with the level of training, clarity of workflow, and ancillary services. And we have step 6, a good plug here for Izzy, the Taming Sepsis Education, TSEP from Northwell Health, so it's really helpful. The VH online module is helpful in that resource. And there's also the Long Island Jewish swim lanes and best practice resources. So these are things that we kind of identify to give to the leaders of those areas to say, look at these resources, maybe they can help you. In addition, for the help, we also look out there to see what groups are really strong in those areas that you may be struggling in. So in the areas that this hospital system with level of training and the workflow clarity, ancillary services, Northwell Health is really strong, positive facilitator, along with Mayo. So we would go out there and look to give them some support from those groups. So we would try to hook them up with people to be a mentor, if you will, to try to help them along to improve. This is what we did at Mayo, or this is what we did at Northwell Health to improve that level for our teams. So this is kind of some of the work we're doing with the pulse checks out there. If you go to the next slide, Jason, the final slide. So this is our unabashed questions here that we ask you guys is, if you're a part of the monthly calls or you're thinking about the pulse checks, how can we help you with the monthly calls? What other kinds of information can we give you? Because we're always looking to add value to our hospital systems that we support. So here's the part where we open up for questions and comments. I might have been on mute there. Here's where we open up for comments and questions. Maybe I wasn't on mute. I don't know.
Paul.
It's so clear, Paul. You don't need to ask questions.
That's right. Well, and Paul, I think this seems like something that maybe teams may consider, more detailed responses, and I'm assuming most people will have your email address that they could email suggestions and questions to as they think through these. What sort of resources are they most interested in getting during those calls?
Yeah, that would be Chrissy Gorman, but also you could do the help at the PMO, right?
Yeah, just the general PMO inbox, the HVHC email, and we can gather those responses and respond accordingly.
Yeah, we're really focusing on what we can do to add value to the collaboratives on these monthly calls. We think the pulse checks are a real good source of that, because that gives you a general idea of how your individual hospitals and system is doing as a whole. So we think there's some value, and they kind of track with your data too. So it's pretty good. It's a pretty good idea to get that feeling of what's going on within your certain groups.
Right, and I would just add to that, in the responses we've seen, of course, those open-ended questions where you type in the issues or barriers and facilitators that you're specifically noticing are incredibly helpful, and we are always using those comments to drive the content of these webinars and, again, other support that is offered through the PMO.
Okay, thank you very much.
Thanks, Paul. So so first of all, I'll check in with Izzy again if you had a chance to dig through for the follow-up question. Maybe not. Is Karen Keel still on the phone? I saw that you had your hand raised.
I'm sorry, I did dig through the reports. I found the February report, but the statisticians did not give me the percentage for everybody. I just have it by hospital. And I do know enough about data that I can't just add percentages and divide them. And so I can get back to you and then get the number at some other point, and I apologize for not being able to find it. I did look.
Okay, well, thanks.
Thank you, Izzy. I appreciate your looking.
No worries. That's why I'm here.
All right. Well, well, let me just check if there's any follow-up questions on Izzy's presentation or anything we've covered in the webinar today. All right. Well, we're going to end just right about on time. So I want to thank everybody for joining, but especially thank Izzy for the excellent presentation. It was fantastic. Again, we have it recorded, so if there are others in your organization that weren't able to join, please let them know that they can view the recording of this event. It should be posted in the next couple days, if at max a week. So again, thanks Izzy, thanks everybody, and I hope you all have a good day.
Thank you.
Bye-bye.